Welcome everybody to our next session of Live from Cleveland Clinic. We're thrilled to have everybody with us tonight. We have a large number of people dialing in. This is Updates in Digestive Diseases, Tiny but Mighty, the New Small Molecules in IBD Treatment. I'm Miguel Reguero. I'm at Cleveland Clinic, and you'll hear from some of my other colleagues in a minute. And this is a program we've been doing for the past 3 years across our surgical and medical and GI specialists. And this has actually taken off, and we're thrilled to have everybody here tonight with us. You've already seen the introductory slide, but there are people from all over the world, and Flo had chatted in already, and I see several of you are chatting in where you are from, which reminds me that we want this to be interactive. So please chat in questions throughout. We'll try to get to as many questions as we can, either through the chat or through the live Q&A session. But these are some of the countries and areas of representation tonight. Again, good evening if you're in Cleveland or East Time Zone for the United States. Good morning, good afternoon, wherever you may be around the world. We couldn't put these programs together without the generous support from our sponsors, and I would like to now acknowledge our sponsors, including Medtronic, Janssen Biotech, Cook Medical, and Olympus Corporation of the Americas. Thank you very much to those sponsors for supporting it. So with that, I'm going to actually turn it over to my co-faculty, Dr. Shubha Bhatt, who will introduce the other faculty and then kick off the program. So Shubha, take it away.
Perfect. Thanks, Miguel. So it's my pleasure and honor to be here tonight. On behalf of Dr. Reguero and Dr. Reader, we appreciate you taking the time out of your day to attend our programming, and we hope that you find it to be really informative and interesting. So on that note, it is my privilege to introduce our faculty tonight. So we'll have Dr. Jessica Popat. She's currently a clinical gastroenterologist within the Cleveland Clinic Center for Inflammatory Bowel Disease. And she's also a clinical assistant professor at the Cleveland Clinic Lerner College of Medicine. We also have Dr. Manuel Braganito also with us. He's an associate staff within the Department of Gastroenterology, Hepatology, and Nutrition, and also an assistant professor of medicine at the Cleveland Clinic Lerner College of Medicine. And lastly, we have Dr. Suha Abhishama. She's an advanced IBD fellow, also within the Department of Gastroenterology, Hepatology, and Nutrition. And we're very excited to have the faculty on here tonight. So on that note, it is my pleasure to introduce Dr. Reguero. He's going to be presenting on S1P Receptor Modulators. He's the chief of the Digestive Disease Institute and professor of medicine at the Lerner College of Medicine. Dr. Reguero, the floor is yours.
Thank you, Shubha. And again, thanks for the kind introduction. So the way we have it set up tonight, I'll provide a 15-minute lecture on S1P. And I think we might have time for Q&A, and then you'll hear from Shubha on JAK Inhibitors Q&A, and then we have time for some interesting cases where all of our faculty will come back. So I'm going to provide an update on S1P receptor modulators in 2023. These are just briefly my disclosures, which I think are also in the program. So really over the past few years, there's been an evolution of therapy for inflammatory bowel disease. And what you see here on the screen now and the kind of the top boxes are the different monoclonal antibody biologic agents, the IL-12/23, anti-TNFs, and integrins. But what we're evolving to, and what you will talk about tonight in the green box, are the non-biologic therapies, are the oral small molecules. I'll focus on the S1Ps, and then again, Shubha is going to talk about the JAK inhibitors. Just briefly, what are some potential benefits from the small molecules? Well, they're an oral administration, so they're taken daily. They have a very short half-life, rapid clearance, and there's no immunogenicity. These don't develop human antibodies against the drug. I think it's also important to note as we really advance our understanding of inflammatory bowel disease and understand that this is really a dysregulated intestinal immune response. And you can kind of see on the left-hand side is a picture of what would be representation of a normal bowel. On the right-hand side, IBD. And one of the thoughts is that there's a dysregulation in the tight junctions in the gastrointestinal tract that allows an antigen, if you will, cross into the submucosa and different layers that leads to this disrupted immune response, Th17, Th1, and ultimately an increase in pro-inflammatory cytokines. Up until recently, the monoclonal antibodies have been directed against cytokines, but we've now really changed our thinking into oral small molecules. So I'm going to talk about sphingosine 1 phosphate, or S1P, which is a membrane-derived lipid that signals molecules in a variety of physiologic and pathologic processes. You can see some of the examples of where this is in the body. Lymphocytes traffic to sites of inflammation along this S1P gradient. So if you kind of look at the top left of this slide, or a lymph node or a lymphoid organ, the lymphocytes egress from the lymphoid organ into the circulation, into sites of inflammation. This is a normal process that occurs in the body in normal conditions, but also in inflammatory conditions along this S1P gradient. What we're going to focus on, and you can see kind of the red X's here, are what happens if we modify, or the S1P receptor modulation, which ozanimod is an example, Etrasimod is another example. How does that work in terms of treatment? This is a very busy slide. Some of the slides I show you will be dense in their content, and I'll really just give you the highlights. I think we'll also provide this information to you that you can review at a separate time as well. But on the far left-hand side, you can see the different preclinical phase 2, phase 3, and then what's commercially available today in the United States and in other countries around the world. So starting with the top left, what's available today is ozanimod. In the phase 3 program, Etrasimod is probably the next that will be FDA approved in the United States, and I imagine other parts of the world as well. But you can see kind of in the middle of this slide, there are different S1P receptors. So S1P1 through S1P5. Ozanimod is the first and only S1P receptor modulator that's approved for inflammatory bowel disease. I think it's important to note that ozanimod was first approved for multiple sclerosis in 2020. So it really has that dual approval for ulcerative colitis and for multiple sclerosis. It's a once daily oral treatment, and again, it's a small molecule. These are the pivotal studies that were performed with ozanimod in the phase 3 program, which led the FDA to ultimate approval for ulcerative colitis. And really, without going through all the bar graph representation, just to highlight, ozanimod in the bars is the dark blue, placebo in orange. And if you look at the kind of fine print, you can see the primary endpoints for induction and for maintenance were met. And in essence, if you think about it, 37%, about 4 out of 10 patients reached a full clinical remission at week 52 on ozanimod, which was statistically significantly higher than placebo. Safety has also been looked at in this platform with ozanimod. And if you look at the induction and the maintenance, and you just kind of scan across your eyes from left to right, comparing the placebo and the ozanimod columns, you'll actually see fairly similar results, meaning that the safety deviation from placebo was very similar, meaning we're not picking up any new signals that we haven't seen with other platforms. And overall, this seems to be a very safe medication. It's important to know that ozanimod may be used actually as first-line therapy for ulcerative colitis. So this does not have to come after another biologic. And interestingly, these are some data looking at ozanimod being effective after just using mesalamine, a 5-aminosalicylate. So these are looking at immunomodulator naive and biologic naive patients. So if you think about your own practice with the S1P class, this can be used fairly early in what I would say the milder end of moderate disease for ulcerative colitis in patients who are bio-naive. Often the question is asked that ozanimod is a lymphocyte trafficking molecule, if you will, and vedolizumab's a leukocyte trafficking. How would ozanimod work after vedolizumab? And you can see that ozanimod was effective. Again, the dark blue is ozanimod and then placebo, but this is looking specifically at a cohort of patients who had been on vedolizumab and then were on ozanimod, and you still saw a benefit with ozanimod. So yes, you can use ozanimod after vedolizumab. There's been some question in terms of age of ozanimod use. So patients under age 60 versus those over age 60. How does this look in terms of efficacy? There are a small percentage of patients, just to remind everybody, about 10 to 15% that are newly diagnosed later in life, over the age of 60. And the bottom line is that ozanimod worked equally well over age 60 and under age 60. When we look at older patients specifically, so over age 60 for safety, so one of the things that often comes up is ozanimod safe to use in older patients? The answer is yes. There were no new signals for safety in a post hoc analysis of the True North program in older patients with ozanimod. So kind of building the story, if you will, for different efficacy outcomes with ozanimod and also safety. So ozanimod's been approved for ulcerative colitis, which is just what I had presented, and that's called Touchstone. Yellowstone, these are the kind of interesting names that always go with trials, is for Crohn's disease. Ozanimod's not yet approved for Crohn's. The studies have been completed, and we'll be hearing report outs from the Yellowstone studies for ozanimod in Crohn's. I'm going to switch gears to another S1P, our sphingosine phosphate modulator, Etrasimod. Not yet FDA approved, but the pivotal studies with Etrasimod, they're called the Elevate studies for ulcerative colitis for induction and maintenance, are coming to completion. And we anticipate Etrasimod will be the next S1P modulator that's approved. Similar to ozanimod, Etrasimod, about a quarter of the patients reached clinical remission at week 12. You can see on the top right the graph with symptomatic remission and time of onset. So these both ozanimod and Etrasimod do seem to work quickly. About 32% of patients on Etrasimod, so about a third, similar to what I mentioned with ozanimod, at week 52 achieved a clinical remission. In terms of safety with Etrasimod, similar to some of what I presented with ozanimod, the safety signals were really no different or significantly different between placebo and Etrasimod. Now, this is just showing side by side ozanimod on the left side, Etrasimod on the right side. You can see the delta differences for clinical remission and clinical response. And I think we're seeing a similar signal for both ozanimod and Etrasimod for ulcerative colitis. And again, there are some slight differences with methodology. One question that comes up quite a bit is, where do we position all of these therapies in terms of safety? Shubha Bhatt, who you're going to hear from in a minute, is the first author. This is actually just accepted to the IBD journal, and we've updated what's considered our new safety pyramid. By the way, we should say a safety pyramid is our opinion, reviewing all of the data on safety for the different agents and treatments that are out there. So this isn't scientifically safety head-to-head comparisons, but this is the way we look at safety. We would cluster in terms of safety. The safest is on the top of the pyramid, and then at the very bottom is steroids, kind of the least safe. We would cluster the integrins like vedolizumab, the IL-12/23s, ustekinumab, IL-23, risankizumab, and now S1P ozanimod. We'd put that at the top. Janus kinase inhibitors, Shubha will go through this, and maybe selectivity will be a distinction. But it's important to know, I put on the right side of the slide, inadequate treatment is an adverse event. So I will still use infliximab with azathioprine for some of my sicker Crohn's patients, especially those with fistula. And also, this is a little bit of a tongue-in-cheek, but sometimes the best human biologic agent is colorectomab. So surgery sometimes is our best approach or best treatment, especially for complicated IBD, Crohn's, and ulcerative colitis. So I'm just going to conclude with 2 slides. These are some practical considerations with ozanimod. Sorry for some of the small print. In terms of safety, where is ozanimod contraindicated? If you've had a patient with a very recent history of myocardial infarction, or they have significant atrioventricular block or significant AV conduction abnormality, those are patients that we would not use an S1P molecule like ozanimod. In terms of what is required at baseline for testing, usually we get a CBC with differential, including lymphocyte count, liver function test. An electrocardiogram is done at baseline, not because S1Ps like ozanimod cause cardiac abnormalities, but this is to detect if there's an underlying AV conduction abnormality that was clinically silent and something we should know. Varicella zoster antibodies should be tested only if a patient's never had chickenpox and has not been vaccinated. So I think that most of our patients have. An ophthalmologic evaluation is only required with a patient who's had macular edema, uveitis, or severe diabetes. Most of those patients are seeing ophthalmology anyway. Ozanimod is titrated up over the first week. That's because there is a known decrease in heart rate in the first dose. They start a lower dose on up, and it comes as a dose pack. So I think that some of the follow-up monitoring is pretty simple, usually LFTs and CBC, similar to what we've done with other patients. So in conclusion, for the S1Ps, we're making some nice strides in the treatment of ulcerative colitis. We know that the S1P ozanimod, we require a dose escalation, as I said, to overcome that first dose heart rate decrease, which, by the way, is usually only 1 to 2 beats per minute. It's not generally significant. Ozanimod has a rapid onset of action, no immunogenicity. Ozanimod is the first small molecule against S1P modulator. Etrasimod will be the next. And we showed data that ozanimod works, especially in bio-naive patients, and we do not need to have this after a TNF inhibitor failure patient. So with that, I think I'm going to turn it back over to Shubha, and I think, Shubha, you might do a brief Q&A for anybody who's chatted in questions, and then I think Florian's going to introduce you for your next talk.
Perfect. Thank you, Dr. Viggo, for a comprehensive overview on the S1P. So there have been a few questions that come into the chat box. One of the questions was, do you think that there are any additional MOAs outside of ozanimod over trafficking inhibition, since it works in vedolizumab failures?
So different mechanism of action for trafficking. I mean, I think it's interesting. So the honest answer is I don't know, and I don't know that any of us really know. When you consider different trafficking molecules, ozanimod, etrasimod, vedolizumab for leukocyte trafficking, there are different targets. And that one slide I showed you had different targets for trafficking. One of the real practical questions is, if you use a trafficking blocker, if you will, can you use another one after? Or does it mean you fail the class? And just to reiterate what I said, even in patients who've been on vedolizumab, we did see benefit with ozanimod. So I wouldn't not use another trafficking molecule if one doesn't work. The real question will come out when etrasimod's available. If you fail ozanimod, will etrasimod work, and vice versa? And I think we'll need to wait and see how that looks.
Yeah, so I think definitely more data is needed, and we'll be looking out for that when it comes out. There seems to be a lot of interest around sleep apnea. So any ideas on why it's contraindicated in sleep apnea?
Yeah, so it's interesting. It actually, in some of the early phase safety studies, it had, based on some of the central effect, there was some initial concern that there would be an impact on sleep apnea. Ozanimod's impact on sleep apnea has been minimal, and there actually have been some post hoc analyses and reviews and at different congresses over the last year where probably the mechanism is not purely understood, but because of the limited effect on the CNS, it's not something we're seeing. So even though it's listed there, I have not actually come across this. A lot of our patients have sleep apnea, by the way, but I haven't had any problems using it. And I guess unless it's a patient who has pulmonary hypertension because of the worst sleep apnea and pulmonaries following, I'm not, it's not something that I would necessarily not use because of sleep apnea.
Yeah, okay. And then one other question, thoughts on transitioning a ulcerative colitis patient who has done well for a couple of years on anti-TNF to an S1P?
Yeah, so my rule of thumb is generally if something's working, I'm not switching them off just because of a new therapy for convenience. However, that's a shared decision that you have to have with your patient. My feeling is that if you induce a remission and maintain a remission, in this case, the questions with the TNF inhibitor, my only concern is if we switch to something else, while the patient's in a deep remission doing really well, you would think you could downshift to an oral small molecule like ozanimod. We don't have enough data for me to cite this, but in my own practice, I get a little nervous that I don't want to move away from something that's working and then find out the next agent doesn't, that we try to go back to, say, in this case, TNF inhibitor. So it's a reasonable thought. I think the sequencing of de-escalation of therapy, which is really the question, is really intriguing. I think we need more data. In my practice, I'm not doing that unless a patient says, I can't get IVs anymore. I need to take something that's oral small molecule. Again, everybody's individual.
Yeah, and I think, Miguel, it's important to emphasize specifically in the anti-TNF situation is that there's a possibility for immunogenicity. So kind of to your point where we don't want to necessarily switch off if they're doing well. I would hate to make that switch if for whatever reason it doesn't work. Then anti-TNF going back to that might not necessarily be a good feasible option. So just want to put that also on the radar. Another question about colon cancer. Do we know if these medications have a positive effect on colon cancer risk over a long time, or is it too early to tell?
Too early to tell. I'll answer broadly, and this is actually some data we have here from Cleveland Clinic and one of our big data analyses. Interestingly, and probably not surprisingly, what we're seeing is a trend is, if anything, there seem to be decreased rates of colon cancer in agents that heal the mucosa. So initially, it would be thinking counterintuitive, like TNF inhibitors, we'd see more colon cancer. Actually, our group published that you see less. I don't have enough to tell you about ozanimod. I can extrapolate that anything that heals the mucosa probably does that. Why does 5-ASA have a chemopreventative effect in mesalamine? It may not be specific to 5-ASA, although there may be something there. It's probably more the healing of the bowel and decrease of inflammation. So my broad answer is I think we're going to see that anything that heals the bowel brings it into remission, whether it's a leukocyte or lymphocyte trafficking TNF inhibitor, probably we're going to see a decrease.
Yeah, I agree with that. I think we all know that the risk of untreated IBD is going to translate to a greater risk of colon cancer. So definitely agree with your sentiment about medications. They're probably likely going to have some kind of effect. I got one last question before we transition. So what if medication interrupted for any reason, whether it's non-compliant, insurance, would it be okay to put the patient back on this?
Yeah, so if it's after 2 weeks, so if the patient's been on ozanimod, say for 3 to 6 months, or as long as it's over 2 weeks, and they miss a dose or miss a couple doses, you do not need to dose escalate again. You can just start back on the maintenance treatment. If it's within that 2-week time period of starting, the recommendation is to restart the dose escalation. Again, the reality is probably the first dose heart rate decrease is so minimal that you probably could get away with it. But the recommendation is within the first 2 weeks of starting, If you miss doses, restart the initiation with the dose escalation after that. And I've had a couple patients call and say they missed their ozanimod for a day or two. I just say, just continue it as long as they've been on for at least 2 weeks.
Perfect. Thank you, Miguel.
Thank you very much, Miguel, for the excellent presentation. And I saw there are several other questions that came through the chat, and we can talk about those later during the case presentations. Also, a warm welcome from me to all of you around the world. My name is Florian Rieder, and I'm the co-director of the session together with Dr. Butt and Dr. Ruggiero. And it's my pleasure to introduce Dr. Butt, who has been transformative for us. We at the Cleveland Clinic, we practice the medical home model, and one really integral part of this is the inflammatory bowel disease pharmacist. And Dr. Butt is the leading inflammatory bowel disease pharmacist, at least in the United States, if not globally. So we are very happy that she's with us, and I learned a ton from Dr. Butt. And I'm also jealous of a lot of things, including her new headset that she just received for Mother's Day from her husband a few days ago. And now we can hear her loud and clear for a presentation on JAK inhibitors. So I'm looking forward to it.
All right, so thank you, Dr. Reeder, for that kind introduction. I'm super excited to present on the other small molecule advanced in inflammatory bowel disease, which is the JAK kinase or JAK inhibitors. And here are my disclosures. So to kick us off, pictured here is Janus, who's actually the Greek god of doorways. And in the next few slides, we'll actually talk about the mechanism and pathways of JAK. But I just wanted to put this in here because you'll see that the naming of the JAK inhibitors is actually quite fitting. Dr. Ruggiero had already provided a great overview about the need for efficacious therapies that need to be administered orally. So I would like to add 2 specific points for relating to the JAK inhibitors. So one, these are actually the first orally administered targeted IBD advanced therapies. And second, the one unique pro of JAK inhibitors is that they actually affect multiple cytokine-dependent immune pathways, as opposed to a single cytokine, which is how most of our monoclonal antibodies currently work. So here, pictured is the JAK-STAT pathway, STAT standing for signal transducer and activator of transcription. What essentially happens in this pathway is that the cytokine binds and cross-links to its receptor. This will then cause phosphorylation of the JAK enzyme, which leads to activation and phosphorylation of the receptor tail. And once the receptor tail is phosphorylated, this can actually serve as a binding site for the STAT protein, which then, once that becomes phosphorylated, can then dissociate, dimerize, and then translocate into the nucleus to be involved in gene transcription. So when we have a JAK inhibitor, it's basically going to inhibit the JAK enzyme from allowing any of these steps to happen, and thereby the cell cannot produce or it cannot have any kind of effect. And so going back again to the JAK picture, the Janus kinase Greek god picture, you'll notice that he's actually, at the god of doorways, he's actually facing both inside and outside. And so this is thought to symbolize JAK because as we talked about the mechanism, the signal is activated outside of the cell and then internally it will translate into a mechanism. So it's kind of like the JAK almost serves at the doorway, if you will. Just wanted to share that interesting fact. So moving on, there's actually 4 enzymes that are part of the JAK family. So we have JAK1, JAK2, JAK3, and tyrosine kinase, which is also TYK2. And essentially, each of these enzymes they can be receptive to a variety of components that include your growth factors, cytokines such as interferons and interleukins. And so one specific example that I would like to point out here is if we were to look at IL-12 and 23, so we know that these are cytokines that are very much implicated in the pathogenesis and clinical presentation of inflammatory bowel disease. And so these are one of the components that can actually activate or act on the JAK-STAT pathway. And what essentially happens is that once this IL-12 or 23 binds, it would then activate JAK2 and TYK2 specifically. and the intended outcome as a result can affect innate immunity, inflammation, Th17 cell differentiation, and proliferation. So again, to the point, the one unique thing about JAKs is that specifically they are widespread, and so if you were to inhibit one, you might actually have several downstream effects as opposed to just inhibiting cytokines such as IL-12 or 23 alone. So within the realm of inflammatory bowel disease treatment, there are currently 3 molecules that are in phase 2 and 3 trials. Main take-home point here is that all of these molecules are being developed specifically for UC at this time, and that they're actually targeting different enzyme pathways. Currently, what we have FDA approved for use in patients is Tofacitinib and Upadacitinib, which I will go into a little bit more detail in a little bit. I also want to add that highlighted on your right is a list of other JAK inhibitors that we have, not necessarily specifically indicated for use in inflammatory bowel disease, but more to highlight that since 2012, we've had a ton of JAK inhibitors, so this is not really like a new class of medicines, if you will. And another fun fact, just to quickly point out, is that Eclatinib is actually a medicine that's used for allergic dermatitis in dogs, so it's not approved for human use at all. But again, just want to put that in here to highlight that JAK inhibitors as a class is not necessarily new and can be used in several indications. So let's actually talk about the medicines that are specific for inflammatory bowel disease, starting off with Tofacitinib. This is a molecule that is approved for moderate to severe active ulcerative colitis and was approved for use in 2018. Listed here, you'll see that there's actually several other indications, such as rheumatoid arthritis, psoriasis arthritis, polyarticular coarse juvenile idiopathic arthritis, as well as ankylosing spondylitis. And the Tofacitinib specifically has a specificity for JAK1 and 3. And you can see here listed is the specific cytokine that the JAK1 and 3 will target. There are different formulations, so we have an extended and an intermediate release available. Depending on the formulation that you use, the dosing may vary, but typically induction is up to 8 weeks. And then dose de-escalation is recommended for the lowest dose possible that you can keep a patient on in terms of clinical remission. And this is designed to help maintain therapeutic effect while trying to minimize some of the potential safety considerations, which we'll definitely dive in into later on. So Tofacitinib was studied for both induction and maintenance therapy, specifically in 3 phase 3 trials that were both randomized, double-blinded, and placebo-controlled trials. So in the active 1 and 2, they included patients with moderately to severely active ulcerative colitis that had tried conventional therapy or treatment with tumor necrosis factor antagonists. And so these patients were randomized to receive induction with Tofacitinib 10 milligrams twice a day or placebo for up to 8 weeks. And the patients that had clinical response at the induction were then randomized into octave sustain, and they were either receive Tofacitinib 5 or 10 milligrams twice a day or placebo for up to 52 weeks. And the primary endpoint was remission, which was defined as a Mayo score of 2 or less, with no subscore greater than 1 and a rectal bleeding subscore of 0. And you can see in the induction that approximately 17 to 18% of patients attained remission by week 8. And of this, 34% were able to maintain that on 5 milligrams twice a day, and 41% achieved that on 10 milligrams twice a day by week 52. So in terms of safety, Tofacitinib had been out for a little bit. I wanted to include more of some of the open label long-term extension data. This had about 7.8 years worth of data, and it included any patient that had been treated with Tofacitinib 5 or 10 milligrams twice a day from a completed phase 2 or 3 trial. So they had about 1,157 patients, and the median dose time, or the median time of being on the medicine was about 900 days. And in this particular study, they had about 83% that were more so on the 10 milligram twice a day, and 36% approximately were on Tofacitinib for at least 4 years or more. And you can see that in terms of incident rate of serious adverse effects specifically, most of them were below 2 with the exception of herpes zoster, but we know that this is a known risk of Tofacitinib treatment, and we'll talk a little bit more about this as well. But main take-home point here is that there really wasn't any new major safety signals identified, and across the board, Tofacitinib tends to be really well tolerated. So like to now switch over into Upadacitinib, and this was recently approved for moderately to severely active ulcerative colitis in 2022, and for Crohn's disease in 2023. And this one also has a variety of indications, immunologic indications, so you might see it for use in rheumatoid arthritis, psoriatic arthritis, atopic dermatitis, and ankylosing spondylitis. Unlike Tofacitinib, though, this is actually selective for JAK1, and so we'll talk about the implications of that as well. But typically, induction of 45 milligrams, depending on the indication, could be minimum 8 to 12 weeks. And then for the maintenance, the dose can be decreased to 15 milligrams, or if the patient's considered to have refractory severe or extensive disease, you might want to then maybe consider decreasing the dose to 30 milligrams daily. And so Upadacitinib and ulcerative colitis was studied for both induction and maintenance, also in 3 phase 3 multicenter randomized double-blind placebo-controlled trials. They included patients with moderately to severely active ulcerative colitis. They were randomized to get OPA 45 or placebo for a minimum of 8 weeks. And then patients that achieved clinical remission in the induction study were then randomized to receive 15, 30, or 30 milligrams or placebo at maintenance. And it's important to note that in the induction study, approximately 47 to 48% of participants in the study had actually tried and failed prior biologic therapy. And so the primary endpoint here in this trial was an adapted Mayo score at week 8 and 52. And as you can see in this slide here, is that at week 8, approximately 26 to 33% were able to achieve clinical remission at week 8. And at week 52, 42% on UPA 15 and 52 on UPA 30. So for Crohn's disease, we had also looked at UPA for induction and maintenance in 3 phase 3 multicenter randomized double-blind placebo-controlled trials as well. And similar setup again, so in the induction period, they randomized patients to 45 milligrams of UPA or placebo, but the duration was actually up to 12 weeks. If patients had clinical response, they could then continue on to the maintenance. One unique consideration here, though, is the primary endpoint. So if you're familiar with the STRIDE-2 guidelines, they actually do recommend to look at both clinical remission as well as endoscopic response, and so that was actually incorporated in this study. And what they found was that in this trial, approximately for the primary endpoint within the induction phase, you can see that approximately 50% to 39%, again, depending on the type of biologic exposure that these patients have had. But approximately that proportion did achieve clinical remission. And then within the maintenance, at least 55% on the higher dose, raised to 42% on 15 milligrams. And you can see that in terms of the endoscopic response, there's a similar rate reported. So overall, pretty promising data in terms of the overall response rate that we've seen with UPA and Crohn's. And I'd like to highlight that there's actually one additional positive finding that we saw in these clinical trials. So one thing to potentially tell your patients about is that there's actually noted to be a rapid symptom relief, potentially up by week 2. And specifically in the trial, so in ulcerative colitis, 62% experienced less frequent bowel movement and bloody stool. And similarly in Crohn's, there's a greater amount of proportion of patients that actually were able to achieve a clinical response by week 2. So in terms of the safety data, the most commonly reported adverse effects among both UC and Crohn were really around nasopharyngitis and acne. But if you want to take a look at more of like the serious side effects or adverse events of special interest, again, I think the main take-home point here is that we saw a really high incident rate of herpes zoster. And so the main take-home point is that that seems to be activated by the use of these JAK inhibitors. And so one important consideration is to make sure that we consider prophylactic herpes zoster vaccination to help mitigate this risk before we start patients on these types of therapies. So one of the major questions that always kind of comes up, specifically with JAK inhibitors, is what is the flashback waning deal? So this actually occurred as a result of the oral surveillance study, which is a post-marketing study that was designed specifically for patients with active rheumatoid arthritis that were over 50 years or older that had at least one additional cardiovascular risk factor. And what they did in the study was that they assigned these patients to receive either TOFA 5 or 10 milligram twice daily or a tumor necrosis factor inhibitor, and the co-primary endpoint being an educated MACE on cancer, excluding melanoma skin cancer. And no surprise, so during a median of about 4 years, the incidence of both MACE and cancer was actually higher in the combined Tofacitinib dose group versus a tumor necrosis factor inhibitor. And the endpoint was actually looking to see if there's actually non-inferiority, and so that criteria is unfortunately not met. So as a result, the FDA has mandated that there needs to now be a black box warning, and you actually find this across all JAK inhibitors with the exception of those that are used to treat blood disorders. Also, as a result of this finding, within the United States, we're not allowed to actually use JAK inhibitors first line. It's only allowed for once a tumor necrosis factor inhibitor has been used and failed. So this is an older version that I stole from Dr. Riguero, and the reason why is I specifically wanted to kind of tease out if there might maybe be a potential advantage of UPA in terms of safety. So far, we do not have like any head-to-head data. There was one study that was recently published, kind of more of an analysis, that found that overall the rates of adverse events were actually the same across both TOFA and UPA groups. However, there seemed to actually be less medication discontinuation in the Upadacitinib group versus Tofacitinib, so maybe something to consider. But I think that begs the question of whether there might be a potential advantage to selectivity. If you recall in the prior slide that I presented, there seems to be a downstream effect because the JAK enzymes are actually involved in several processes. So maybe inhibition of one specific enzyme as opposed to 2 or 3 might actually translate into a better safety profile. I think we need to wait for more data to see, but I think in theory, that's the general hypothesis as we know it now. So similar to Dr. Riguero, I'd like to present some practical clinical considerations with the JAK inhibitors. So again, in terms of main considerations to think about when you're thinking about what population you might want to use this in, you definitely want to be a little bit cautious about those that might have existing cardiovascular risk factors. And again, this is more coming from the oral surveillance. Nothing really from our safety data has seemed to kind of trigger that this is a major concern, but again, just kind of following along with the current recommendation, we should probably be a little bit more cautious about using patients that have existing cardiovascular risk factors as well as malignancy. I did not go into specifics about this, but pregnancy is another concern. So if you do have a female patient that has childbearing potential, there is a recommendation that contraception needs to be used during treatment and 4 weeks after. Unfortunately, there's not a lot of great pregnancy data. We do know that small molecules do cross the placenta, and in animal studies have been shown to be teratogenic. So definitely a consideration that we want to keep in mind. The other unique thing compared to some of the other medications that we have for inflammatory bowel disease is that there are drug interactions that we need to definitely be monitoring for any CYP3A4 inducer inhibitor co-use. Those adjustments will be needed in that setting, as well as there are considerations for renal and hepatic impairment if present. So more things to kind of think about, definitely in terms of making sure that we're using these medications not only effectively, but safely. In terms of baseline clinical assessment, I would recommend a tuberculosis and a hepatitis B panel, a complete blood count, a comprehensive metabolic panel, again, to check on hepatic and renal consideration. And I did not go into too much details about this, but we do know that JAK does have an involvement in lipids. And so there have been a increase seen in lipid panels in the clinical trial. What is the clinical utility of this? We haven't completely determined that yet, but it is recommended that we do obtain a lipid panel at baseline, and depending on the agent of use, this should be rechecked in about 4 to 12 weeks after starting treatment. And if it is elevated, then it should be appropriately treated. Some of this may tie back in again to some of the cardiovascular risk factor concerns around these medicines. And then lastly, one thing that we keep emphasizing is that there is an increased risk for herpes zoster, so making sure that we're definitely preventing this at within our patients. And so there is a shingles vaccine out within the US that recently got FDA approved for use in patients that are 19 and over that are considered to be immunocompromised. Insurance coverage has been a little bit of a struggle, but now I'm hoping that in the next few years we'll be able to overcome that. And we're definitely recommending that these patients should at least have one dose on board. As the dosing sequence is typically it's the first dose administered, and then the second dose should be given within 1 to 2 months of that prior dose. So making sure they at least have one dose on board so that we can make sure that these agents are safely used. So in conclusion, a lot of similarity between what Dr. Reguera presented, but just would like to highlight that though we have 2 treatment options currently for ulcerative colitis, Upadacitinib is the one that's indicated for use in Crohn's disease. There are some safety considerations that we need to be mindful of when it comes to JAK inhibitors, making sure that we definitely are screening our patients at baseline to make sure that they don't have any significant risk factors, assessing for renal and hepatic impairment and drug interactions, and lastly, vaccinating them with at least one dose of the shingles vaccine prior to treatment initiation, and making sure that we're assessing for any potential family planning planned up ahead of time so that we don't run into the situation of a patient becoming pregnant on treatment. And I think that's kind of like the quick run through about JAK inhibitors. Probably could spend an hour talking about this to really dive into the intricacies about everything with the treatment, but hopefully that was kind of a good brief overview.
Thank you so much for the introduction to JAK inhibitors, and we do have a bit more time to the cases and before that in the Q&A to learn more from you about JAK inhibitors. So before I ask the panel to come on for the case presentation, we have a few questions for you, Shuba, from the audience. The first one is, you have 2 JAK inhibitors available for UC, Tofacitinib and Upadacitinib. Which one is better or which one is stronger? Are there any comparisons between the 2?
No, so no comparison to date. I think that there might be a hypothesis possibly floating around that UPA might perform a little bit better because if you see in the clinical studies I presented, it's actually a higher clinical remission and response rate noted, and it could possibly be due to the dosing. So upadacitinib dosing is probably a lot higher as opposed to tofa dosing. So and I think that if you were to talk to gastroenterologists, there might be a slight bias towards UPA as well.
Yeah, and there was one at the last ECHO conference, one poster that mathematically compared the 2 trials with each other, exactly what you were saying, Shuba, with the result that Upadacitinib may be superior to Tofacitinib, but I want to ask for a lot of caution with these mathematical or statistical comparisons without having a direct head-to-head. And another question was, do you have any clinical experience using JAK inhibitors in IBD and primary sclerosing cholangitis, apart from few evidence in the literature?
Yeah, so I personally don't have any experience. I know that this is definitely interest that Dr. Reeder has, because I know that there's talks about potentially looking to see if we're using this in our patient population and what their outcomes were. So I can hand that back to you, Dr. Reeder, if you're able to share your experience. But I definitely know it's an area of interest, and I would say mechanistically it could make sense because we're hitting upon multiple cytokine and multiple pathways as opposed to one. So that's likely probably implicated in PSC as well.
Yeah, and we have very few patients, in fact, on JAK inhibitors with PSC when we looked at our own population. And this is the specialty area of Dr. Catherine Falloon, who's going to join us on staff in a few months, who just finished her IBD fellowship, who is now running a multi-center study through her extraintestinal manifestation consortium to look at JAK inhibitors in PSC-associated inflammatory bowel disease. And there is only, to my knowledge, one study with the European consortium group, less than 50 patients, looking at PSC, UC, and JAK inhibitors. And it was safe. It worked just as expected in the colon. And it was in the liver, there was a reduction in alkaline phosphatase, which is unclear what that means long-term, what that means for severity of PSC. But I'm looking forward to the data that Dr. Falloon and her consortium group will generate. So it was one interesting question, then we can dive into the panel and work through the other questions in the cases. Are these molecules effective in pouchitis?
Good question. So I think there might be some preliminary data floating around. I'm not 100% sure on this, but I think I've heard rumors about it, but haven't personally looked into it yet. But again, mechanistically. So I will say this for what it's worth, is that there was I believe like a network meta-analysis that was recently presented. And I will say that UPA had actually been positioned to be really probably like one of our top tier meds within ulcerative colitis. So for what it's worth, again, just knowing mechanistically how this medicine works and like all the good safety and all the good efficacy data we've seen, it wouldn't surprise me if it actually has some good comparative effectiveness for pouchitis.
Yeah, and there is like you mentioned, just a few case reports. There is a prospective study that has recently been got additional funding in Australia from JAK begun, who is testing Tofacitinib in pouchitis, which I think will be really interesting. And I agree with you, Struba, that the mechanism will likely also work in pouchitis. The last question just popped in, and that would actually be interesting for all of us. For patients under age of 50, do you have difficulties with insurance coverage for Shingrix? And while Dr. Butt answers, I would ask the panel to come on.
Yeah, so definitely, yes, unfortunately. So the recommendation did get updated earlier this year to use in patients that are, again, 19 and over that have an immunocompromised condition. I would say that insurance typically lagged in terms of adopting the updated guidelines. So it's kind of been a hit or miss in my experience. We've had a good amount of patients that have been able to get it without any issues, and then there's been a small portion of patients that are still haven't been able to get it and need to pay out of pocket. And it can be pricey. It's about $200 something per each dose. So we're talking about a $400 dose series just to get up to speed on the vaccine. I'm hoping that this landscape will change soon though, because this guideline has been out for a few months now, and so it's a matter of time before the insurance is update the formulary and policies, and so hopefully it won't be a widespread issue going forward.
I hope so too, and we're going to dive now right into the panel. I asked Dr. Butt to stay on, and I welcome back Dr. Rigero, and then Dr. Philpott, who is a senior inflammatory bowel disease specialist at the Cleveland Clinic, Dr. Braga Neto, who just joined us from the Mayo Clinic, who is a physician scientist that is new to our team, and the presenter will be Dr. Abu Shama, who just had her fellowship graduation yesterday in a very nice ceremony, but we will only be away from her for short because she will join us in August as one of our IBD specialists, which we're very happy about. So the last presentation as an IBD fellow, the floor is all yours.
Great, thank you. Can you see my slides?
Yep, we can see it.
Perfect. So I'll jump right into case one. So this is a 35-year-old female with a history, with a history of obesity, her BMI is 39, and a family history of premature CAD, who presents for a second opinion regarding ulcerative colitis. She was diagnosed with left-sided ulcerative colitis about 6 months ago at another hospital. She was started on mesalamine 4.8 grams oral daily, and she had declined topical therapy, both suppositories and the enemas. And she now comes to see you about 6 months into her disease. She is compliant with the mesalamine oral therapy, but she notes no improvement in her symptoms. And she currently has 4 to 5 occasionally bloody bowel movements per day with lower abdominal pain. You check labs and her CRP is elevated around 4, the upper limit of normal being 0.9. Her fecal calprotectin is 400, and she has a normal hemoglobin and albumin. So you do a colonoscopy, and as you can see from the pictures, she has extensive Mayo 2 colitis with a normal TI. I'd like to hand it over to the panel and ask what you would do next at this point.
Yeah, I have a couple of questions, in fact, for the panel. A very practical question first for Dr. Braga Neto. So the patient had oral mesalamine 4.8 grams. In what instance, so how would you describe the disease severity in this patient? And then in what instances would you add on rectal 5-ASA before you switch to a different agent? Are you muted?
I think I'm not muted. Thank you. No, that's a great question, and I think from a practical standpoint as well, like here, just making sure that we're ruling out superimposed C. diff, and so that's something I think just to make sure that we're excluding. And that's a really interesting, like from the standpoint of practical question. When we think of if we think of left-sided and particularly proctal sigmoiditis, there is a role to combine oral and topical therapy to maximize your efficacy. And usually in these cases, when you have more extensive disease, less likely that you'll have necessarily a benefit from adding a topical agent unless you have really severe kind of proctitis that may potentially improve with the topical therapy. But in this case, from the symptom standpoint, I would say that moderate to severe disease. And then from the standpoint of like the endoscopic evaluation here, you definitely see, I'd say Mayo 2. There isn't, we don't see all of the colonoscopy here, but perhaps even some evidence of spontaneous bleeding there. There's more than just a bit of erosions and also loss of vascularity, erythema. So I'd say Mayo 2 and maybe a few components of Mayo 3 there. So in this case, I would say that potentially adding topical therapy would not be of benefit, especially because if it's extensive. And the patient has also demonstrated that she doesn't seem to be potentially going to be compliant with it.
So extensive disease and too severe to add on topical therapy to already existing 5-ASA.
Correct.
And I agree. I would not do that in that instance. So Dr. Philpott, as an experienced IBD provider, so this patient is treated with 5-ASA, and you do a colonoscopy and you find patchy disease. So the rectum looks kind of okay. Descending colon, there are some ulcers. Transverse is disease-free. Ascending colon has a Mayo 2 score. So could you walk us through how do you interpret colonoscopies different in patients that are on therapy and treated? How would you score it? How do you monitor it?
Well, certainly, I think what you're alluding to is if I start to see patchy disease as opposed to contiguous from the rectum, am I looking at more of a Crohn's or an indeterminate colitis? And then is that going to alter my therapy? And certainly in patients that have partially treated disease, we may see some of that patchy nature. And so I think I'm just going to look at this person as a whole person. I am going to look at my histologic findings, although it's rare that you get the win where your histology tells you what you're dealing with, right? If I have some granulomas, then I know what I have. But I'm looking at the severity here. When I have pancolitis and I have these type of labs, like an elevated CRP, I know I'm dealing with a more aggressive form of the prognosis in this situation is worse. And so I need to act more aggressively and more quickly and not try some things, but move on to my next therapy.
Yeah, very good. So the point I tried to make is even if you see patchy disease in someone with diagnosis of ulcerative colitis on therapy, it's not necessarily Crohn's disease. It could just be because of partially treated ulcerative colitis. So Dr. Riguero, what therapy options would you consider here? So the field is wide open, failed mesalamine, 4.8 grams a day, moderate disease severity, but has quite some comorbidities. So how would you deal with this patient?
Yeah, so I think briefly to your point, you could use any of the three anti-TNFs, infliximab, adalimumab, golimumab. You can use an anti-integrin, vedolizumab, or you could use an IL-12/23 ustekinumab. The only oral small molecule you could use right now is ozanimod. Upadacitinib and Tofacitinib need to be positioned after a TNF inhibitor. So to your question, which of all of those would you use? Interestingly, her BMI is 39, and you wonder if the anti-cytokine therapies, monoclonal-based therapies, work less well. There are some data specifically with anti-TNFs, and the adipocytes may be actually having a TNF morphology. To that end, she, to me, is still in that moderate end. She's just failed a 5-ASA, so she's in that kind of milder end of moderate, I would say. I would be okay with ozanimod. To be very transparent, though, if she was on the severe end of moderate or severe, I'd use infliximab. The other thing is her clearance of drugs. The small molecules don't clear as quickly. The family history of CID doesn't concern me. If she had heart block, that would be different with ozanimod, but family history of CID that would not concern me.
Okay, so the choice is ozanimod. Dr. Abu-Shamma, did we choose ozanimod for this patient?
Yes, we did. So she was started on ozanimod. Her symptoms improve. Her CRP normalizes and her fecal calprotectin is down to 80 after 3 months. But in the same labs, you notice that her white count now is 2.9. Previously, it was more than 4. Her absolute lymphocyte count is 850. Her ALK-Phos is around 4 times the upper limit of normal, and it's 440 now. Her ALT and AST are both around 5 times the upper limit of normal. So what would you do next?
Before we dive into the next steps, I have a question for Dr. Butt. So we rely on you a lot in clinic to start medications. And Dr. Aguirre already nicely highlighted how to start ozanimod. Could you walk us through what you talk to the patient about before you start, and then how do you start ozanimod?
Yeah, so I think Dr. Aguirre highlighted some of like the baseline labs and tests that we will need to get. So there's definitely some checklist things that we need to make sure for ozanimod that we are completing. So you definitely want to make sure we're getting a blood count, a complete blood count, and that should also include like the lymphocyte value in there as well, so that we can use that as a monitoring parameter going forward. You should definitely get your basic like your CMP. And then we basically need to make sure that at baseline there's no contraindication. So looking to make sure that from a cardiac history, the doctor already touched upon this, but making sure that there's no contraindication from a cardiac sleep apnea. If they have diabetes, making sure that we've done a uveitis, ophthalmology check to macular edema. And so there's a few checklist things that we need to kind of go through. So clearly that patient has kind of exceeded all of that. And so from a monitoring parameter going forward, I think we kind of hit upon it. So we're looking at the 3-month labs here, and you'll definitely notice that the white blood count has definitely decreased, as well as the lymphocyte count.
Yeah, thank you very much for walking us through it. And before I ask Dr. Braganeto what to do next, I want to ask Dr. Philpott, so are you concerned about these labs? Is that something where we have to stop with ozanimod? Is the lymphocyte count outside of what we would anticipate?
So we know that patients, when they're on, the mechanism of action for ozanimod is that it's sequestering the lymphocytes in the lymph nodes. So we certainly are going to see a reduction in the lymphocyte count, and it's something that we monitor, but it's expected. And that's what they couldn't really blind the studies when they did the randomized controlled trials, because when you looked at the CBC, you knew what they were on. So that's something I'm going to monitor. I'm not alarmed. The liver tests, of course, are concerning. I assume she had normal prior to initiating. Now, in general, as we check the liver tests. There certainly are reports of elevations of like some of the like the AST in general, but usually like progression to liver dysfunction or liver failure has not been reported with that therapy. So anyway, it's a concern if you see an abrupt change in your labs when you've initiated a therapy. Of course, you're going to be concerned that that's causing it, but it's not necessarily the typical pattern seen with the abnormal liver tests seen commonly with this drug.
Okay, so would you so you say lymphocytes okay, liver tests unexpected? Is that something you would stop with ozanimod for?
Well, if I could, I'd quickly, round up the usual suspects. So, I get an ultrasound. I do some testing for other things. She could have fatty liver. So I would look into that fairly quickly. Because it's a fast-acting drug, and it also has there could be, and it's not immunogenic. If her liver tests continued to get worse as I was working this up quickly, I might have to hold it until I had a better idea of what was going on.
Okay, so maybe Dr. Braganeto, what would you do next?
Yeah, so I agree completely with Dr. Philpott and this kind of assessment here, and in particular, I think bringing up as well like the lymphopenia, just thinking about like the severity of it. In this case, it's still mild. It's not really kind of grade 3 or 4. And it's usually a reversible kind of side effect when it does, develop. But the liver enzyme elevation does concern me. I don't recall having associating ozanimod with elevation of alkaline phosphatase per se, more of like the transaminitis kind of pattern. Definitely excluding viral hepatitis there as well, autoimmune hepatitis, but this is more of a mixed pattern. So it could potentially be, drug-induced could potentially be something on top as well. Whenever I have like patients with ulcerative colitis, in particular, if there's elevation of alkaline phosphatase, that always does raise concern for like cholangiopathies, and in particular PSC. We know there's about 5% of patients with ulcerative colitis that have PSC. So that's kind of also in the back of my mind. But I think in this case here, excluding the viral etiologies of hepatitis and then also autoimmune hepatitis, if those all come back negative, and that's kind of a quick, usually workup, then holding the medication and trending the enzymes.
So I agree with almost everything. I would rule out other causes for elevated transaminases, but if they all come negative, I would feel comfortable continuing with ozanimod for a bit and see where the liver enzymes trend. If they continue to trend up, I would hold it. But if they trend down, I would probably continue. How would you do it, Dr. Aguero? And then you could answer also a question: does the patient need an MRCP?
Yeah. So, well, the MRCP question I'll answer first. What the person's getting at is, does this patient have primary sclerosing cholangitis? I would say certainly an evaluation of the liver. I mean, obviously starting with an ultrasound is reasonable, but yes, to answer your question, I think an MRCP would be very reasonable. I agree with you, Flo. So the absolute cutoffs for when you need to stop ozanimod is if the absolute lymphocyte count gets below 500 and the abnormal ALT/AST is 5 times normal. Now, this is getting to the point where you wouldn't ignore it, but in the studies, there's been transient elevations in LFTs and lymphocyte decrease that actually normalize just by continuing ozanimod. Probably like Flo, she's done really well. I'd probably give it another week or two, but this is something I would worry about. I don't think it's ozanimod, but I wouldn't be cavalier and say, oh, keep taking it, come back in a few months. You're going to want to follow up. To your point, if you were to hold it, then I think the question becomes, do you go to a monoclonal antibody? You can't use upadacitinib or tofa yet. I would have a discussion probably between an anti-TNF and an IL-12/23, and then it gets down to kind of her preference IV versus sub-Q. If you had to say use one, I might say use adalimumab at this point, and then if she fails that, I'm moving to upadacitinib. So you've already opened the door by using a TNF, but I don't think any of them would be wrong.
Okay, so adalimumab and one word answer, mono or combo?
I use combo. You obviously have to watch out though with her labs the way they are with thiopurines. Check a TPMT. And I would use azathioprine still, but I would wait a week or two.
Back to you, Dr. Abushama.
So her ozanimod was actually discontinued, and after discussion with the patient, she was started on adalimumab monotherapy. Her LFTs continue to improve. However, the AST and ALT still stay elevated like 3 times the upper limit of normal. They go down from 5 times. And the ALK-Phos continues to be significantly elevated and actually goes up to more than 5 times the upper limit of normal. So she does get an MRCP and it shows findings of PSC. So she is diagnosed with that. Her symptoms unfortunately continue to worsen in adalimumab. Her inflammatory markers are elevated. She gets a 6-month colonoscopy after initiation of adalimumab that shows Mayo 3 colitis. So the decision is made to switch her over to a JAK inhibitor. So as part of the pre-JAK inhibitor workup, she gets a fasting lipid panel. You can see that her total cholesterol is 440, the upper limit of normal is 200, her LDL is 350 and HDL is low and triglycerides are normal. And again, her LFTs, her AST and ALT still stay about 3 times the upper limit of normal. So what would you do next?
So Dr. Bhatt, you said earlier that JAK inhibitors can increase lipid levels. So how do you deal with a patient like this when she gets sent to you and say, please start a JAK inhibitor?
So no dice, these are definitely elevated. So I'd probably treat it like just clinical hyperlipidemia. So I think in this case, even before she even starts the JAK inhibitor, we could probably refer her back to a primary care doctor or a lipid clinic to see if she would be a good candidate for starting a lipid lowering therapy. So this is just more in conjunction to kind of treating it more from like a hyperlipidemia profile. Again, there hasn't really been any strong correlation with JAK the increase in terms of the lipids. Like we don't know what that clinically translates to, but there's definitely a correlation that's seen. But again, from a basic hyperlipidemia consideration, I think this should definitely be treated.
One actually very hyper quick thing. Actually, in the label, you don't need to check lipids at baseline, only after 12 weeks. I think all of us check it at baseline for this very reason. Obviously, she's obese. She has a family history of CAD. You can almost do that no matter what because of her cardiac disease. For the audience out there, though, in a young, healthy patient, technically the label says you don't need a baseline lipids, although I do it. You need a 12-week lipid. The problem is if 12 weeks, you don't know what to compare it to if you don't have the baseline.
Yeah, I think this is a very good point, Miguel. And since we are almost at the end, I want to capture at this point some of the questions that came from the audience to make sure everyone gets a part of the answer. So there were a few questions that came through the chat, and one was on the duration of induction of JAK inhibitors. And perhaps Dr. Philpott, I'm going to ask you, so what is your experience of extending a Upadacitinib induction beyond 8 to 12 weeks?
So, I mean, basically, the patients usually at this juncture that we're starting on JAKs have been through a number of different advanced therapies usually. I mean, by law, at least one. And certainly there is some data that extending the induction can actually pick up some more responders. So I think for UC, it was going to 18 weeks and picked up to 50%. And then Miguel answered, for Crohn's disease, a lower dose, but they, again, were able to achieve response. And so in patients that had not had a response at the traditional induction, to extend that induction, we were able to achieve some response in a good portion of those patients. So although, and I guess that's a little bit paradoxical because we say these are fast acting drugs. And yet for some patients, we have to be patient, and it's hard to be patient when, oh, I just went out, sorry.
No, you're still on.
Okay, so it's hard to be patient when your patient's very sick and they want to get better yesterday. But yes, so that we certainly have evidence, and we want to continue to, for each patient, if we're having there are some patients that it's appropriate to extend that induction, really to try and achieve long-term remission for them.
And to Jessica's point, and I know we're almost out of time, in the ulcerative colitis trials, as she said, you are allowed, based on the label, to give another 8 weeks of 45 milligrams for ulcerative colitis. For the Crohn's trials, it was 12-week induction, 45 milligrams standard. There was no extension of 45. However, as she said, continuing 30 for 8 weeks maintenance, you did pick up some patients. I find about a third of the patients I'll find with a second course for UC or just continuing 30 in the maintenance, you'll pick up about a third of patients. So don't give up too soon, even though it works fast.
Very good. And the last point, and then I hand it to Dr. Butt for closing the seminar. The last point that was discussed in the chat is what do we do with the mesalamine in these instances? And I agree with Dr. Reguero that you can stop mesalamine. You call it cold turkey when you start advanced therapies. There are some instances where I overlap or may even change to, for instance, a rectal formulation. This is when mesalamine had some effect, so you can somewhat bridge the patient over, or when there is residual disease activity in the rectum, for instance, in ulcerative colitis. Sometimes an addition of a rectal formulation, in my experience, was helpful, even though in the clinical trials, mesalamine does not suggest to work on top of an advanced therapy. So thank you very much to our expert panel, Dr. Braganeto, Dr. Philpott, Dr. Reguero, and Dr. Abu Shama. When she will be next time with us, she will be a full part of the panel as our IBD staff. And I give it back to you, Shuba.
Perfect. Thank you, Dr. Reader, and hope everyone enjoyed this session. I think it was jam-packed with a lot of information and definitely a lot of informative discussion. And lastly, please make a calendar notice to join us for our next live from Cleveland Clinic broadcast. On July 12th, we will be presenting on endoluminal surgery for gastrointestinal neoplasia. And on August 9th, we'll be keeping it simple. Have we lost their way with performing complex hernia repairs on routine defects. So hope to see you there. Thank you and have a good night.